Hello, everybody. Welcome to today's live webinar. As some of you may be watching this as we're in the recording, but we want to thank you so much for joining us today. We have a new first-time speaker, a friend of ChiroHealthUSA, Dr. Bill Owens, and I'm super excited about his topic of conversation. Working with students is like a huge passion for me. And he's going to be talking to us about fellowship programs, which is so apt right now because I feel like all I have been doing for the last couple of months is working on new fellowship programs at colleges like Yale, Harvard, Dartmouth, and the fundraising for that. And so I am so excited, Dr. Owens, to have you here today.
Wonderful. Thank you so much. It's great to be with you. I'm happy and excited for the invite. And yeah, let's have a conversation and let's talk about what's been going down.
Sounds good. Take it away.
All right. Well, just a little background on myself. By the way, how long do we have, Christy?
We have an hour, so take all the time.
Oh, we have an hour. All right. Good. So I'll slow down my my speech. And listen, if there's any question or anything that you want me to elaborate on, just interrupt me. Sometimes we talk about industry vocabulary so much that we forget that it's industry vocabulary. So I've been in faculty in family medicine at the Jacobs School of Medicine in Buffalo since 2014-ish, I think. And in that time period, I was actually invited as a member of family medicine to go through a program through the Royal College of Physicians at the school. Now, Royal College of Physicians, the acronym is RCP, and they're the oldest academic medical organization in the world. They were actually founded in 1535. So you can imagine what medicine was like back in 1535. I'll let you think about that. But one of the things that they are tasked with doing, and they travel the world and they go to all the various medical schools, and they're tasked with teaching clinicians how to become attending doctors. Meaning, if I'm in a room and I'm treating a patient, that's one thing. But if I have a student along with me, it's really changing sort of the paradigm, right? I'm dealing with the student. I'm dealing with the patient. I have my business to run. All of those things it's not an innate thing. You have to go through some training. So this program was a year long. And in that group with me, I had an interventional radiologist, 2 neurologists, 2 emergency room physicians, a pediatric neurosurgeon, a general surgeon, and a neurosurgeon. So that was just our small group. Our entire cohort was about 45 people. So I was the only chiropractor. And at the time, I believe I was the only chiropractor that had gone through that program. And after that year, essentially, we spent a lot of time on understanding the difference between a young learner and an adult learner. And as we get through medical school, and particularly, they focus a lot of time and energy on that. And for them, that would be more based on their residency and fellowship program. So once you graduate medical school, you become a medical doctor, but you're not yet board certified because you have to go through your clinical training. And that's essentially what a residency is. In family medicine, that residency is 3 years, for example. Neurosurgery, it's 7 to 9 years, depending on what you're going through. So this program was really designed to train the leadership, train the physicians on how to be that kind of teacher. And, as I watched and I looked at how much energy, time, finances that medicine is putting into the graduate programs, I was kind of a little bit shocked. There's not much left to do in terms of evolving literally medical school. So what they're focusing on is enhancing the experience of that clinical encounter. And that's just a process of maturity for that profession. Now, taking all of the politics out of it, if we look at it just from an academic perspective, I had a high level of interest in why that was happening. And as I talked to these doctors that were in my cohort about where chiropractic is, where we could take it as a profession, I was impressed with the level of support and curiosity. And everybody in that room was there to also help me to do whatever it kind of took to get us more exposed to real patients. And we know that in chiropractic education, that patient encounter is the most important thing. But managing cases, being in front of high-end neurological conditions, post-surgical care, all of those things need to be part of the clinical experience. But just like in medicine, there's not a lot of room for that in the traditional 3 or 4 year program. It has to be expanded. And as a matter of fact, medicine has 3 different academic organizations that oversee this process. So, for instance, in medical school, we have, or they have, a governing body called the Association, or I'm sorry, the Accreditation Council on Medical Education, ACME. That's just for the medical school. Very similar to our CCE. They interact with the Department of Education. They get credentialing, they get funding, and all of that stuff. It's for the school. But where chiropractic ends with CCE, medicine has an additional oversight nonprofit that is very similar to ACME, which responds and governs the criteria for the graduate programs. So those would be all of your fellowships through, like I mentioned, primary care and neurosurgery, as well as all of the intricate workings and the research and the things that go on in those programs. And that acronym stands for the Accreditation Council on Graduate Medical Education, which is the ACGME. So the ACCME, the Accreditation Council on Medical Education, ACME, is very similar to our CCE, and I'm throwing out a lot of acronyms here. The ACGME is the graduate level oversight. And then lastly, they have a third, which is the ACCME, which stands for the Accreditation Council on continuing medical education. Okay. So that ACCME is where we get all of our coursework approved. All of the fellowships are approved through ACGME, and the actual school's criteria are governed by ACME. Now, that was an evolution that took a very, very long time. And if you look at the process that medicine went to get through that to increase their education, it's a very similar process to what we're going through in chiropractic right now. And it's an important and a natural evolution of our program. Because without those training programs, we don't get the clinical exposure and we don't get the interaction with other professionals in the system to help consult and help us manage cases. So historically, as it should have been and still is, chiropractic is centered around a particular type of treatment, which is the chiropractic adjustment. And we've held on to that. That's what's made us unique. And in fact, that's what that's what kept us going. That's what kept us alive. It was the patient satisfaction with the chiropractic adjustment that was allowing them, those patients, to get better. But as we move farther and farther through the process, what we start to see is it's not just the proficiency in the treatment that chiropractic provides, but it's proficiency in understanding chiropractic's space in the larger healthcare system, and also how we can serve a very unique, credible, and important purpose and helping to route those patients through the healthcare system so that they get the care that they need in an expedited fashion, and we're not wasting resources or over-relying on medical procedures such as opioid prescriptions and surgery. And that takes training. That's not in, as I mentioned before, in the attending situation, managing cases is not an innate behavior. You know, we do need training. And it's critically important that we have that training in the context of clinical exposure, because you can sit in a classroom and a presenter can tell you all sorts of very important research-based, patient-centered evidence on how to do things. But unless you're doing it, and unless you watch a surgeon examine a patient in their room and struggle through understanding maybe the mechanics, or a family medicine provider wondering what to do next, those are shared experiences that help us to become better doctors of chiropractic, but also help us to teach the medical specialist how to use us. What's our lane, right? And this is really critical. So coming out of that Royal College of Physicians training, we had 2 projects, and those 2 projects were due at the end. And in order to graduate, you had to submit them. They all had to be written up academically. And one of those projects is the National Spine Management Group's fellowship in spinal biomechanics and trauma. And what that special sort of level of training does is it helps a doctor of chiropractic that wants to build a practice that is inclusive to the greater healthcare community, a practice where other healthcare providers, surgeons, primary care, pain management, internal medicine, peds, emergency room doctors, and even attorneys want somebody that can help coordinate and diagnose what's predominantly wrong with that patient and let us guide. And if you want a large practice, I still practice. I'm at my practice here today. I've been in practice for 25 years. We have 4 doctors of chiropractic in our practice, and we focus mostly on that diagnosis and management of the biomechanical component of spine pain. And historically, we would call that vertebral subluxation. When I went through national, we called it spinal fixation. We call it biomechanical pathology. We call it a lot of things. But it's really the mechanical basis of why the spine hurts. And that is in conjunction with the medical providers that treat the other 2 aspects of spine pain. Chemical, which is inflammation and swelling and edema. And secondly, structural correction, which is the surgery realm. Now, conservatively, most of the time when we treat the biomechanical component, we're helping the structural and we're helping the chemical. But there's a subset of patients out there that maybe have a traumatic injury or have a chronic spine pain problem that needs to be managed on the medical side along with the chiropractic component. And it's at that time that what we don't want to see and what the patient doesn't need is the chiropractor to release the patient from chiropractic care and actually wander the wilderness of medicine and try to self-advocate for the procedure that they need, they require, and is medically necessary. So in terms of that, the training is about immersion into those other disciplines that your patient may or may not experience. Microdiscectomy all the way up through disc replacement and maybe spinal fusion at single or multiple levels. Interventional pain management in terms of a facet block, medial branch block, an ablation, even trigger points, right? Epidural steroid injections, whether they're interlaminar or transforaminal. All of those procedures, although we're not doing them, for us to be the right advocate for our patient along that pathway and paradigm of care, we need to be able to understand the clinical indications for those and what type of provider should be providing those and why one versus the other. As an example, every Thursday, we do a 1-hour clinical grand rounds from 7 p.m. to 8 p.m. Weekly. Those grand rounds are approved for continuing ed credit through chiropractic academia, through University of Cleveland, Kansas City, PACE, and also the medical school. And the goal of this is to provide a platform where we talk about case discussions. And one of the past ones we did was, why would a patient that is non-responsive to chiropractic care and have a spondylolisthesis, what's a better referral? Is it the surgeon? Why wouldn't you send to the surgeon? Or is it the interventional pain physician? And if it is, which it is in most cases, the interventional pain physician, what kind of injection? Are we looking at an epidural or are we looking at a facet? And how do you know which one? So the training, if you have the mindset of wanting to be treated as a doctor and be able to be part of the system, you have to have that training, right? You're not going to learn this on your own. And even if you try that, it's a 10 to 15 year process. So what we put together is a system of training that lasts a 24-month period. And, I want to highlight, too, that as we evolve as a profession, we're really going to need, and we're already doing this, we're stepping away from the term like diplomate. Okay, we're the only profession that uses that. And although those programs are a high level of training, there's 2 important reasons why we should step away from those. Number one is nobody understands outside of chiropractic what a diplomate is. There's no national standardization across professions so that they can use the term diplomate and understand where our training truly is. The second reason is that we don't have the clinical exposure in a diplomate program. We're not necessarily like the old days where we would just sit in a classroom. Now, granted, there are some smaller fellowship programs in chiropractic that are very, very focused and are immersing doctors in clinical care. But those are few and far between. And unfortunately, that's because we just don't have access to the patients in large systems. But, I want to share with you that that's changing. Now, in terms of the exposure, we have a couple different components, right? We have, and think about this in terms of an evidence-based triangle, right? The one corner of the triangle is the doctor's experience, me being out 25 years. I have a different approach sometimes than a newer graduate, and that's just because I've been around. But that's not enough, right? It's not enough to make it evidence-based. The second component of evidence-based care is the patient's response. Are the things we're doing to them having a positive effect, and are we gaining traction on the goals that we set for the patient? And then thirdly is, well, what does the science say? What does the research say about all of these things that we're doing? So we have the doctor's experience, the patient's response, and the content of the research being published. Now, last weekend, I spoke at the Southern Chiropractic Association annual meeting in Tennessee. And, that 2-hour lecture was based on the validation of chiropractic. And, I had some doctors that were a little bit more seasoned than me say, why are you even giving this lecture? We know it's validated, it works. And I said, that's absolutely true, but the rest of the medical profession and sometimes courtrooms don't. And that's our job now. Our job is to take that validation that we've experienced over 25, 30, 50 years and put that into a place where we can go shoulder to shoulder with other healthcare providers and discuss cases live. So the fellowship program, again, focusing on a 2-year fellowship program. We use the term fellowship because it gets people's attention. We jokingly say it's the F word, right? And when a doctor of chiropractic says, I'm enrolled in a fellowship training program, it gets people's attention. But it's critically important, and this is the point that I can't stress enough. Any fellowship program, in order for it to be a true fellowship program based on the definition of fellowship training, it has to have a clinical rotational component. It's not a classroom-based program. You can support a fellowship with classroom or what we would call didactic work, and that's important to reinforce. But it has to be clinical. And think about our founding fathers, right? The clinic was always the place of learning, and going home and reading books or writing textbooks was reinforcement. And somehow we moved away from that, where the classroom is now the main source of education. And the clinical side as well, it's nice if we have it, but we're trying to throw all of these things at our students. That's why this fellowship has rotations. And there's actually 11 different rotations that the doctor goes through. Now, what's super important is that this fellowship, when I got out of Royal College, started about 2016. We have about 120 people that are either in the program or graduated since then. And it's very important to their community, and their practices are really thriving in terms of referrals, respect, credentials, all of those things. That's not the reason for today's talk. But what I want you to understand is that when we started, we went to what we called a community-based model. And that was, listen, we can provide a robust level of training. In fact, you could come to Buffalo. You could go to one of our sites out in Lehigh, Utah. You can go to a soon-to-be site in the southern southwest United States and up in Illinois. And you could have a wonderful training experience. You can do all of your rotations. You could sit around and feel really good about yourself. But the problem is that when you come home, you don't have any of those relationships. And it was really critically important to me, and this is what I wrote up in my Royal College project, was that we had to do a community-based. You have to go through your rotations locally with my help to find out who those providers are and rotate with them. You can't do it over Zoom. You can't do it over, the telephone. You have to be in those clinics with those providers, seeing those patients and talking about what's on the MRI. How would you look at it? Well, this is what I would look at. Here's an X-ray. This is the first thing I see. How about you? And what are you doing with the patient? Did they get better? And there's hundreds of examples of how chiropractic really became proficiently used in communities because of this clinical understanding. So those 8 rotations go through that process. And what we do is we reinforce that with 2 ways. So just like the evidence-based model, we have the doctor's experience, the patient's experience, and the clinical research. We've incorporated that evidence-based model into the fellowship program. And that's done in the following ways. Number one is we've partnered with a internationally based neuroradiology training company that works with neuroradiology residency programs across the United States. And we have a 1-year advanced imaging training program that walks you through everything from normal spinal anatomy all the way through degenerative diseases, spinal cord tumors, a complete review of the vascular structure of the brain and spine, everything about disc herniation, protrusion, sequestration, all the way through bone anatomy, bone tumors, peripheral nerve entrapment coming out of the spine, brachial stuff, all of that. And that's a 1-year program. That's actually included in the fellowship. So as you're going through this 2-year program, you're going to be going through the rotations that I'm going to share with you. And you're going to be learning advanced imaging protocols and diagnosis along the way. Not for you to become a radiologist, okay, because we have our DAC bars and there's certainly neuroradiologists out there. But this is to enhance your knowledge and their vocabulary and their understanding of those pictures so that you can apply it to your patient. And when we do that, we start to see that it enhances our understanding of the patient that's in front of us, and particularly on the provider that we're referring to. On top of that, for each one of those conditions, there's 15 modules in the MRI course. There's anywhere between 10 and 15 research papers that you would read in conjunction with those images. And this is all studied, or you're studying this via video and case presentation. So it's a series of patients on, say, seronegative spondyloarthropathies like ankylosing spondylitis, right? And they would show you pictures of that. They would talk through cases, but you're going to read a review of the research on AS. And you're going to say, oh, right, I remember that. And I remember, here's the clinical indications. I wonder what that looks like on an MRI. I wonder what that looks like on a CT scan. I wonder what a neurosurgeon would do with that. Well, here's your modules. And you would learn that from a didactic perspective. But while you're going through and reading the research and doing the imaging, you're also going to be set up with clinical rotations in your community. Now, that community-based model starts with the following rotations. Okay, we do a pain management rotation where you're going to rotate through their practice, and you're also going to watch them do procedures, those medial branch blocks, the facet ablations. What's the temperature that you need to heat the nerve up during an ablation? Most doctors of chiropractic don't know that, right? But once you observe it, you'll never forget it, right? So pain management, there's a clinical and a procedural. The next rotation is MRI tech, and that would include CT. So you sit with the tech, you watch them push the buttons, dial the needles, you understand how the crosslinks work, you understand how to position the patient, you understand what the views are all about, the slice thicknesses, all of the things that are critically important in diagnosis. The third rotation is neuroradiology. So you sit with the radiologist and you go through those cases. And again, just like the advanced imaging course, each rotation contains a block of research that you will read to prepare you for that encounter. So when I go in to see the pain management doctor for that procedural rotation, I understand why you would choose an interlaminar approach for an epidural steroid injection versus a transforaminal, right? Not to do it, not to become a pain management doctor, not to reduce the impact of me having it as a chiropractor or giving chiropractic adjustments to my patient, but to understand exactly what should be done and how it should be done right? That's critically important. So the research is really a profound part of this, because if you don't understand what the research trend is around these things, it's going to be really difficult to stay current and get your mindset affiliated with a process, right? So we did pain management, we did MRI tech, we did neuroradiology, and then the next is orthopedic extremity, so shoulder and knee. Understanding, we know the difference between cervical spine and shoulder, but have you ever watched an orthopedic surgeon examine the shoulder and try to rule out neck, right? Most of us haven't, and all the chiropractors in the country, most have not seen that difference. And watching the surgeon focus in on that shoulder while we're focusing on the neck, it makes sense that we would integrate our thought process, but by learning and watching each other examine the same patient. Now, most of the rotations that we're doing are observational. We're not necessarily interacting with the patient, right? And there's a variety of reasons for that. But understanding what that surgeon does is really, really important, right? Because it helps us to gain a perspective on where that patient's going to go and what's expected. Same with low back and hip. Is that a labral tear in the hip? How do you diagnose a labral tear? Is that a referred pain from discogenic back pain, or maybe a facet? Right? Or is it just back pain? All of those things play critical roles. And what I'm trying to share with you is the clinical experience. 1 hour of clinical experience, in my opinion, is worth 10 hours of studying a textbook. It's that profound. After the orthopedic extremity, now you do your rotations, you're set up for your rotations in orthopedic spine, and you watch how an orthopedic spine fellowship trained spine specialist does surgery. Right? How they approach it more from a structural perspective, how they do their preoperative planning, how concerned they are about pelvic incidence, sacral slope, and sagittal vertical alignment. All of those things that chiropractors talk about. But how does the surgeon apply that for their implant? And what do they do before, and what do they do after? And where's chiropractic space surrounding that? Those are things that are taught during the fellowship. Now, the most interesting part is contrasting that orthopedic spine fellowship trained specialist to the neurosurgeon, which is the next rotation. Now, for each of the surgical components, including pain management, ortho extremity, ortho spine, and neurospine, what we're doing is we're seeing them both in the clinical setting when they're in their practice, evaluating and doing physical exams, just like us. And then we're observing the procedures. Now, when we go to neurosurgery, there's an additional layer of information that neurosurgeon looks at. They're very focused on minimally invasive type of work. They might be involved more in just decompressing the nerve. They might be doing endovascular stroke work, right? So those are all the exposures that you're getting exposed to in those rotations. And a lot of the research on the neurosurgery side is all of the vascular injury, how we can prevent complications to chiropractic adjustment. And you're really going to be able to go through and be proficient at discussing those things. It comes up. And as a doctor of chiropractic, you should have an evidence-based, valid answer, right? It's our profession and it's our job to make sure that we are training doctors to be proficient. After the neurosurgery component, then we're going to emergency department. Now, that emergency department could be an overnight. Preferably, it is an overnight experience. But if not, I want you to see when people come in, how they're triaged. What is the primary motive of the emergency room physician? How do they behave when somebody comes in with neck pain and they've been on a 16-hour shift and they're the last patient after they've sewed up a gunshot wound and maybe lost a patient to myocardial infarction, right? What's the mindset of all of these providers as they're going through, and where can we help and where's our lane? Now, remember, we're seeing 7% of the population. There's an entire 93% of the United States population that has never been exposed to us, right? And they're being seen by all these medical providers. So doesn't it stand to reason that the quickest way to build your practice is to have them send you those 93%? I would agree with that, 100%. After the emergency department, now we move into the family medicine or internal medicine, which is rotating through the primary care office. So all told, right, when you have your advanced imaging, you have your clinical rotations, and you have your research, when it's properly organized with my help, we can do this 2-year program, 24-month program in about 5 to 8 hours per week. Because remember, you're already seeing patients. So your clinical experience will grow exponentially as you see these patients, more patients come in from the referrals, and your education profile is going to be significant. Now, That was from 2016. So we're going into our 7th year of doing this in a community-based model. And, really we're sitting around and, our advisory board, we're talking about, okay, what's the future? Is this just a community-based program? Is this just for DCs in the field that are out 5 years all the way up to 40 years? Is that where this ends? And it became clear pretty quick in those meetings that no, in order for this process to create the system of educational standards like ACCME, ACGME, and the ACME, right? In order to turn CCE, the Council on Chiropractic Education, into the foundation for graduate level training, we need to go to the schools and we need to create a placement and we need to create an employment opportunity for new graduates to go out into the community and be trained for those 24 months in centers of excellence across the United States that are run by fellowship trained doctors of chiropractic that can take them through that same paradigm that they went through themselves. Okay, we're moving past this idea that I practiced 25 years, so I know more than you. Okay, longevity isn't expertise by any stretch of the imagination. Training produces expertise. So what we're going to do, and we just started having talks with 2 chiropractic institutions, and we're going to start a pilot coming this January 2023 with taking students out of graduation. They have gone through an externship cycle with our fellows that are out in the community and at institutions. They are going to then stay on for a 2-year process within those clinics or within those institutions and be trained just like all the fellows that came before them were trained. They're going to get their exposure. And then while they're producing income as a fellow, right, once they're trained, that income level now becomes significantly different. Okay, because when I came out of school, my only option was to get an associateship and be somebody's workhorse. Okay, and not that there's anything wrong with that, but we tend to become more technicians as opposed to learned doctors because we enter busy clinics, right? And we need to pay our loans. We need to start generating some income, so we take that because it's only one of 2 paths. The other path is for me to start in my own practice. And, like anybody out there, if anybody tells you that it takes less than 10 years to get on your feet, they're not being truthful. Until we create a system within the chiropractic profession that doesn't rely on entrepreneurship to be successful, we're never going to elevate ourselves to the level that we need to elevate ourselves. Once that 7% utilization becomes 30%, and I believe that's going to happen within the next 5 to 8 years, we're not going to have enough trained doctors of chiropractic. And as I had mentioned before, the training has to be clinical. Anybody out there that says that you can be a proficient clinician by doing some website work and getting a certificate, all that does in my eyes is make us a little bit smarter, gives us something to brag about, but it doesn't give us the clinical experience that the healthcare system is looking for. Because I can tell you, when I sit in the grand rounds at the neurosurgery department up here at University of Buffalo, when they ask you a question, if you haven't rotated and you haven't seen what they do and how they think, your answer is going to be really kind of vanilla. And that's the profession's problem. Our answers typically are vanilla, and that's why we get confused with other professions. And most medical doctors will eventually say, you know what, I don't really understand this, so I'm just going to send them to physical therapy, right? And I work with a lot of physical therapists, and that's an important part of the care paradigm. But it's my belief that the properly trained doctor of chiropractic is truly in a position to be the guiding provider during that time frame. Today, I just went and taught the first-year med students. We do a facilitation group in the fall. And that's all on the basically the connective tissue genetic disorders like Ehlers-Danlos syndrome, Marfan's, Fragile X, osteogenesis imperfecta, all of those. And we go through that. But it used to be when I started, they were kind of taken aback that there was a chiropractor training them on this. And now It's just a regular daily activity. You know, here's an instructor. But a lot of that has to do with my exposure to them, not necessarily their exposure to me. So the idea of this fellowship program is really designed for you to elevate your practice while you're building it. Okay, this isn't something that you do before you build your practice if you're in the community. And it's also going to give you as a student an ability to apply for a fellowship position in one of our 13 sites across the United States. And that's what's fundamentally going to change chiropractic. Now, is this fellowship type of fellowship for everybody? Absolutely not. My hope is that this structure of this fellowship program is a pathway and a model for other fellowship programs, because it's this expansion, it's the relationships with other physicians, it's the relationships with hospital systems and physician groups that are going to allow chiropractors to come in and learn, right? Because that's the secret, the T word, training. Anytime you approach somebody, particularly in the medical and the legal professions, and you try to fake it till you make it kind of thing without training, it's going to be exposed. And we're seeing more and more need for what we do. So what I would really like to have is forums that challenge the status quo, challenge how we're training doctors of chiropractic, get them exposed to more clinical work, and then let's put them in positions of leadership because they have that training, right? And for the most part, too, that goes to our clinical instructors. As I had mentioned, when I sat through the Royal College, you know, those doctors, very high income earners, right, had very prestigious clinics. But why were they going through a one-year fellowship, spending a year of their life to be trained to be a clinical instructor so they can become an attending physician at an academic institution? The reason they were doing that is because in medicine, that's the highest level of achievement that a clinician can get, is an academic appointment. Unfortunately, in our profession, we've always joked, you know, if you can't do it, then teach it. In medicine, that's the direct opposite. And those are coveted roles that are actually highly competitive, to the point where, just as I mentioned, clinicians will go through a one-year training program to compete for those positions. Because in the end, when there is a epidemic, when there is an interest in some sort of disorder, let's say prostate cancer, right? They don't call the clinician on the corner of Main Street and North Street, right? They don't call the president of the American Medical Association. Who do they call? They call Dr. Jones, the chief of staff and chief attending clinician for the Department of Urology at the State University of New York at Buffalo Jacobs School of Medicine. Because those academics are the people that are charged with creating the pathway by which medicine is trained clinically, okay? That's the opportunity that we have here. We have the opportunity to take the clinicians that we have in our academic institutions and elevate them. Elevate the exposure, elevate the position, because in the end, what happens in medicine doesn't go to the community and promote the residents. They don't go into the community and promote the fellows. Medicine goes into the community and promotes the attendings, right? The reason you should come to University of Buffalo Neurosurgery is because of these attendings who are published, who teach and travel the world and understand the highest level of endovascular surgery in stroke patients anywhere. Come spend time with us. Let us diagnose you. The residents are helping, but it's those attendings. So that is why medicine has to absolutely work to create a training program to help those doctors that are being vetted to be put in those positions properly. Because in the end, the patient flow is critically related to that. That's why these academic institutions are so busy, okay? It's not because they have some marketing gimmick or they have some sort of cool new treatment. It's because of the credentials of the doctors running the program. And for far too long, I've seen, clinics across the country, and I've been to most of the schools. I've gone through the schools. You've gone through the schools, and we could do a much better job of increasing volume, but we're not going to do it unless we elevate the attending stature and we compensate those doctors properly, and we promote those doctors to the medical and legal communities in those surrounding areas, because that's where the people are. That's where 93% of the population resides. And it's those cases that are going to help our interns gain exposure. Once the intern is graduating and doing a preceptorship, then they have a lot of choices. But one of those choices might be to enter a 2-year fellowship program in spinal biomechanics and trauma, training you to become a spine management physician, to be hired by a practice group or a large institution, to be a chiropractor, to adjust patients, but also be preliminarily and long-term put in the role of advocating for those patients to reach the right provider at the right time. That's what this entire program is about. That's the mission of the National Spine Management Group. And 25 years from now, when I'm hanging up my pisiforms and I'm done with the chiropractic profession and who knows doing what, the thing that I want most for our profession is to leave it better than I found it. And in my case, in my brain, and the people that we work with, and the evidence that we're seeing already preliminarily, leaving it better means creating graduate level programs that are meeting the same standards as medicine, but are chiropractic centric. Okay, I want to be very clear about that. Academic standards are there for a reason, and I believe we should meet the highest standard, if not exceeding it. But we have the opportunity to make these programs chiropractic centric and elevate the profession like we've never done before. This is our time. This is our time to put forth those academic programs, create a graduate training infrastructure so that when we're talking to our politicians about the Medicare Modernization Act, it's not just a bunch of chiropractors complaining that we're feeling discriminated against. This is basically us being compensated for the level of training and the work that we're doing to constantly and never-endingly improve the stature and the academics of those doctors coming out, helping our attendings, flooding our schools with patients, and working truthfully with that 93% of the US population. That's my goal. We're seeing it happen. If you have interest in helping and working and becoming an attending or whatever, everybody plays a role, and it takes a collective. It's not ever about one person. If one person tells you that they're in charge of doing it, it's going to fail. Nobody's self-made. It takes a group. And I invite you to just learn more about what we're doing. Come along, give us your expertise, give us your life experience, tell us your story. Let's help raise the lake for all boats, because we're going to be in charge of creating that industry, nobody else. Thank you. Christy, so I finished a couple of minutes early. I don't know if you want to jump on and, ask any questions, if there's any concerns, if you've had any chats in there. Are you there?
I don't see any questions or chats. I will say, though, if you are watching this in the recording, which hundreds of people do, if you pop your question in the chat box while you're listening to this presentation, it automatically sends me an email to let me know that you have a question. And I will get that over to Dr. Owens and his team so that they can follow up with you to get an answer to that. And I've updated your contact, Dr. Owens, in my email so that it's the correct email address.
Right. It's always winning the communication battle, right? And if honestly, sorry, I'm interrupting you, but if I would say, if you're listening to this and you don't even know where to get started, or you're like, that sounds great, but I don't know, can I do any of this? It doesn't matter. Just join us on the grand rounds. They're free. And just hear our fellows talk and learn from us and share some of that knowledge. I think that's a really simple way to start. And anybody can do it. If you have a computer or an iPhone or one of the other phones, you can certainly log in and listen. It's an hour out of your day. And if you need that, just, shoot me that email and, we can get that out to you.
And I think that's like just an incredible opportunity for everyone to be able to just experience that. I know that Dr. Foxworth has too. And, he had like he gained a greater respect for healthcare as a whole by going through that process and listening to that.
Yeah, absolutely. Because it empowers us, I think, right?
It does. It absolutely. It's like you don't know what you don't know.
Right.
So
That's for
it's
sure.
just a really incredible opportunity. So I really do encourage y'all to reach out to Dr. Owens and really take an opportunity to take advantage of this and see what it's all about. So Dr. Owens, thank you so much. And if we do get any questions in the chat box, as I was listening to this and hearing everything you had to say, this is one of those moments, y'all know I'm famous for saying that I never think of questions till 30 minutes to an hour after a presenter has stopped speaking. So I will forward those questions because I imagine they'll come as they are processing this information or even reviewing it again.
Yeah, absolutely. And this is a process of conversation. We never learn in one sitting. So it's a constant, ever improving cycle. And, I thank you for giving me a platform. I'm reaching people that I couldn't ever do by myself, which is exactly what I said. Nobody's self-made. So I appreciate the opportunity and the trust that you guys had in putting me on this, because I could have said anything. So thank you.
You could, but then I knew better that you wouldn't. So,
Okay.
I joke all the time. It's like we call the ChiroHealthUSA webinar series. We should just call it Christy and Friends. It's like I have to know you a really long time to know before I let people be on the webinar
Yes,
series.
it's going. We've moved from the kids' table to the adults.
Yes, but I still feel like I'm at the kids' table, but we'll definitely have to bring you back on. I was just thinking too, it was like, man, everybody's traveling to FCA National this week.
For sure.
And so normally even for our in-person attendance, although there's so many more people who watch the recordings, but this is going to be one that's going to get hit in the recordings even more so than usual because everybody's wrapping up and traveling today and tomorrow to get to Florida.
Oh, as they should, and that's the communication battle, as I've said before, with busy healthcare professionals. We have to find a platform where we can get information, but all of our timing is different because of the different levels of family obligations and academics and clinic and all those kinds of things. So having a recording is really probably one of the most important things, and finding the time to actually record it like we're doing now sometimes is even more of a challenge. But I appreciate everything that you've given us.
Perfect. Well, I hope you have an amazing rest of your day and a fabulous week, everybody. Just a reminder, next week we're going to come off of FCA, the National. Make sure you stop by the booth and say hello if you're there. But we'll be back on Tuesday with Brandon Steele talking about the 10 most impactful skills for chiropractors in 2022. It's another first-time guest, longtime friend. We never can get our schedules worked out, Brandon and I, to ever make this webinar happen. So I'm super excited about it. It's a good thing I'll see him at National, so I'm going to have to remind him that it's next week.
I need reminders. I saw Heather at Tennessee, and she said, "Hey, can't wait to have the webinar." And I'm like, "Oh man, you're right." So yes, it helps. Gentle reminders are the key to success.
They really are. And it's also super helpful if you have somebody's current email address and didn't even realize it was your old one. But I went in there and I was like, delete, 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 and then pasted in the new one.